Welcome to VNA Health Highlights, a program of the Visiting Nurse Association of Cape Cod. I'm Jeanne Sarnosky, and on today's program we're going to learn a little bit more about hospice in general terms. And we're lucky enough to have as our guests today Tina Soares and Jamie Nunes, right to left, who are both part of our VNA hospice program. So thank you both for being here today. I appreciate your time. And I always like to start with the audience getting to know who you are. So because you're closest, Tina, you get to, how long have you been with the VNA and what brought you to us?
I've been with the VNA for 4 years now. Okay. I've been doing hospice for 3 years. And I initially came into the VNA on the certified side. Okay. But I really desired to coming to hospice right away because of some personal experiences.
Okay. Yeah, because it's a unique field of study for people to transfer from regular care into the hospice care program.
It is.
Yeah, yeah. And what about you, Jamie?
Well, I've been with the VNA for 14 years, going on 14 years. I've been with the hospice department now for about 6 years in a variety of capacities. And I think what brought me to hospice care was some of my own family experience. I had an opportunity to care for my grandfather at home on hospice services long before I thought of coming to hospice, and that was really kind of a watershed moment for me. It really spoke very deeply to me. So when the opportunity came within the VNA, I took it.
Oh yeah, good for you, good for us.
Yes. Very good.
Yeah. So how long has hospice been around?
A long time.
A long time?
A long time. Yeah, I mean, it goes back to the late 1800s, 1900s when the movement first started. In terms of formal programs, it's more in the 1960s, you know, the first,
in the US.
Right, first official programs were begun.
Okay. Can we talk a little bit about, I know a lot of people, and people that I run into, think of hospice as a place. And it's not really a place, it's more of a philosophy of care. You want to touch on that a little?
And that's exactly right. Hospice isn't a place, it is a philosophy of care, and it's care for people at end of life, and a care focused on maintaining comfort and promoting quality of life, however long that amount of life is.
Usually palliative care is a word that's used at the same time as hospice. Is that a fair statement that they always go together, or can somebody go immediately from right into hospice without palliative? Or
They can. Palliative care, it also describes that someone's symptoms are going to be treated. We want people to be comfortable. Palliative care in our program is the patients who may be diagnosed with cancer or an end-stage cardiac, but they're continuing to pursue treatment like chemotherapy or radiation. We bring patients on to palliative care in hopes to transition their care and bridge them into hospice eventually.
Okay. So it's a nice sort of connection during your process from one to another. Does a person need to change their physician? People get so attached to their physicians, you know, always.
No, they do not need to change their physician. And sometimes specialists are involved, maybe a cardiologist or a urologist or oncologist, and they still very involved with the patient as well as their primary care provider. We really like that team approach when we're working with families and with patients.
Okay.
I'm sorry, we have the added benefit of having a medical director who's a physician who also consults and oversees the care that we provide and helps coordinate it.
So the medical director could play the role of, if there's a question from the team that's we're having trouble with, he's somebody or she is somebody we can tap into for their expertise on hospice care?
Exactly.
Correct.
Yeah. And you mentioned the hospice team, because it's more than just the doctor or just the nurse. There's so many more people involved. Do you want to talk a little bit about if somebody's on hospice care, who will they see?
They will see a team, and that is one of the things that makes hospice care unique, is that we are totally a team approach. On that team, you have obviously your medical director, the patient's physician, primary physician, if that's the signing physician. You have the nurse. You can have home health aides. You can have a little bit of therapy, physical therapy, occupational therapy, if excuse me, if that's appropriate to what the patient needs. We also have volunteers who can come out and help, social workers, and homemakers, and I think I got everybody
Yes.
there, so
Yeah,
it's
okay.
quite a few people.
It is.
You have bereavement, so there's
Bereavement,
some follow-up.
Some follow-up after
People is
or
involved.
even prior to someone passing. If the family has had a loved one pass recently, or if there are small children in the home, we often refer bereavement earlier, and that team can
to
go in and
prepare
start to
them a little.
provide some counseling, and it's worked
Yeah.
out wonderful. We have a great bereavement team that stays in touch with the family.
So I'm going to back up just a little for the thinking that hospice is a place. So hospice is a type of care, a philosophy of care. And can that happen anywhere?
It can, and the hospice can happen in the patient's home, which very often we will be in the home taking care of the patient. It can be an assisted living facility. It can be in a skilled nursing facility. It's wherever the patient is. We meet the needs of the patient.
That's a good way to think of it. Wherever the patient is.
Wherever the patient is.
The care is
and sometimes
provided.
that patient may transition from home to a facility, or from facility to home. And we've done a great job really coordinating that care. So we really meet the needs of the patient that way, and what serves best for the patient and the family.
So you can follow them if they move from place to place?
We can.
The same caregivers or type of care that you provide goes with them?
We do.
That's good. That's good.
They can't lose us.
All right. Is it care that's provided 24 hours a day? Or
Hospice philosophy is that the families are the primary caregivers. You know, if the family's in an assisted living facility or at home, we treat that as the patients in their home, and it's the family's responsibility to be the primary caregivers. We go in and assist as much as possible, putting in our services and support, bringing in our team. And some patients are in skilled nursing facilities, where if they are getting that extra care from the skilled nursing facility, we work with them to make that happen there. So some patients can't always stay at home, and we make sure that we meet the needs of where they are.
okay.
So, did I answer that? You know, that's full of.
So do you train family in some things
We
in the
do.
care? So if they're in a home situation and there's other people in the home, they all get involved somehow?
Yes, yeah, and the 24-hour aspect of hospice care is that 24 hours a day there's a nurse on call. So if it's 2 a.m. and something is going on with the patient, they're having pain, you know, anything's going on, that caregiver can pick up the phone and talk to a nurse, get some reassurance, get some troubleshooting, you know, some recommendations about how to get the patient comfortable, or coordinate to have a nurse come out even if it's the middle of the night. So there is 24-hour coverage. We're not physically in the home 24 hours providing the care.
Okay, but you're available for support and questions.
are.
I think that's a great thing for viewers to know, that there must be a sense of sort of being in this alone.
Comfort and trust, and I think we have a nice team that we do get to know each other's patients very well, and if family does call, you know, they're not just a number. We know what's going on, and we're able to assist them.
And there's more than one of you that knows what's going on.
Yes.
Yeah. And you're on laptops as well.
We
Yes,
are.
we are.
So even if there is a switch in a caregiver, anybody can access, not anybody, but anybody within the team can access all your history and can do that research that's needed to whatever question has come their way.
Yes.
Okay.
So that should be
Real consistency of care.
okay, a little more reassuring for people. Now, this is probably the hardest question. Even when I read through the scripts ahead of time, I think, oh, that is a toughie. How does someone know when it's time for hospice? Does someone know, or does someone
Well,
take them down the path?
There are a lot of factors that go into that, but by and large, if you think of somebody who has a chronic progressive disease process and one that, you know, they've kind of exhausted all of their treatment options, and their physician feels that if their disease process continues to its natural conclusion, that they will come to end of life, you know, probably within 6 months. That's an educated guesstimate. It doesn't mean, you know, that they can only be on for 6 months.
Yeah.
Right. But to the best of the physician's ability to judge, that's where the patient's at in their disease process. And many times patients, if they have been undergoing like a curative treatment, chemo, things like that, and it hasn't been going well, they may themselves decide that it's time to stop the treatment and they just want to be kept comfortable. So that's something that will open the conversation about
Right.
hospice.
So does that happen very often? That where a patient comes to that realization on their own?
It does.
Does it?
And I have to say, in my experience, and I know Jamie can say this too, is very often when patients do stop treatments, they start to feel a little bit better. They start to have a little bit of quality in their days. And I've fortunate to have had patients that had several months of great quality of life before passing. It was such a great experience to see how much they enjoyed their family, enjoyed their days, that, you know, it was such a, they were just so happy that they decided to choose hospice.
Yes.
And
So that came about because they stopped the curative treatments, and they can be hard on the body and you just feel lousy all the time, so your quality of life is crummy.
And we always, you know, it was a choice. The patient knew that continuing the treatment was not going to cure them. It was only going to prolong maybe some
okay.
time. So very often patients have to make that decision of what benefits are really they're going to receive from
Right.
continuing with treatment. And then very often they are happy that they've made that decision if they've able to feel better, enjoy some days.
Yeah, because they've come there on their own, and it's
Exactly.
a relief to say, okay, now I know what I'm doing.
Yes.
And the physicians are always very supportive too.
Are they? Yeah, that was my other question.
They
so
are.
The other way would be for people that maybe are in denial or just are not going to quit fighting, then the physician is the one that takes them down the path of, hey, we've done all we can do, and they make the recommendation then for hospice.
Yeah, that certainly can be the scenario. But we at the VNA have the added benefit of having our palliative care program, so that if somebody is truly in denial and not able to kind of emotionally cope with the concept or the word of hospice, we can still support their symptom management needs and focus on quality of life under our palliative care program. So that's kind of an added benefit that we have.
And then hopefully they get more comfortable with what's going on and then transition.
Right. Then they have had the opportunity to build a trust with us, a trust with their nurses and the social workers and so forth. So they may feel more comfortable making that leap.
Would they have the same caregivers in between the palliative and hospice
We
programs?
do.
So you have the
And
same.
many patients value that.
Yes.
That they don't have to switch to a whole new team, same nurses. And, you know, it's, in making those decisions, it's always what's best for the patient.
Yeah.
That's what we put first. What's best for the patient, what's best for the family.
Do you think people are getting, in general, in society, more comfortable with the concept of hospice than, say, even 10 years ago?
I think so.
I think so in some respect. I think it's more of a known quantity, but I think there's still a lot of misconceptions about what hospice is.
Yeah.
And many times those may be factors that dissuade a patient from, you know, saying, okay, it is okay to come over to hospice.
Oh, yeah. What are some of the misperceptions that you run into of people that are...
Well, you know, again, that that they're going to die immediately once
Right.
they come onto hospice, that
It's a death sentence, that means, yeah.
exactly.
That we set a time. It's the timer starts as soon as hospice starts, and that's
It's all
not
over
the case.
now.
Yeah.
Yeah.
That idea of giving up, is something
yeah.
that sometimes will dissuade people. There's a
Yeah.
lot of emotion that goes along with making that decision.
Yeah. Are families involved in that decision as well, or does it end up being pretty much one-on-one with the patient and the physician, or the patient and the caregiver?
It should be a team approach with the patient and the family. Have a discussion, and generally the physician's involved as well. And the more family support is usually the better. And it's a lot of educating, and educating the family and then the patient. And as long as they're well informed, they generally feel more comfortable making that decision. And the physician is part of that.
Yeah. Do you have people that come on to hospice and go off and come back?
Yes.
Is it?
Yes.
Yeah.
Wasn't too long ago we had a patient graduate from hospice, and they had to be discharged completely because they no longer met the hospice criteria. They were enjoying themselves, having some quality of life, and it seemed like everything was going well. So
They rally. That's what that
rally.
seems to be the terminology that's out there.
And
Right?
if they
somebody
eventually
rallies, and all of a sudden
exactly,
it seems like
and
they're
if,
not.
eventually they may come back to us, but when it's time. So
Yeah.
we have seen patients that come onto our services, do really well for a couple months, and we have to reevaluate.
Yeah. Yeah. That's great, really.
It is.
Let's talk a little bit about the uniqueness of VNA hospice because of all the other pieces that come with it, as opposed to a standalone.
Well, first of all, we are part of Cape Cod Healthcare, which I think is fantastic because we like to focus on continuity of care for the patient within the system. And when a patient can come on to palliative services, we are unique in that we offer that. Not all hospice providers do have palliative care.
Is that right? Yeah.
We do. And so that's bridging that patient from palliative services to hospice has been a great concept for us and very supportive for the families. So that is one unique aspect other than being part of Cape Cod Healthcare. We can focus on the palliative piece.
Do you hear from our own, because were you both in certified? So
Yes, we were.
do you get many that come right from our certified, recognized by our own team as maybe time for this one to transition, someone to transition to palliative or hospice?
We have a good rapport with the nurses and certified. They will send our intake person an email saying, could you look at this patient? I feel that they're probably hospice appropriate. And then we'll review the patient record, talk with patient or family and the physician, and make sure that it is appropriate, and then we'll go out and do an informational and an actual screening for hospice.
So it's nice for, I'm thinking of the viewers thinking, so when we talk certified, that's the other thing, is we talk certified in a different light of what does that mean. So that's people that would be normally under our home care services. So they're being sort of, somebody else is keeping an eye on them all the time, which is a nice feature
Right, and
to have.
If they're on certified services, they have a skilled nursing need that the nurse is going in to help them. It could be based on their diagnosis or a post-surgical event. And if we do have patients that we've known over the years, especially on certified, again, that's that nice continuum of care that we can continue to provide them services in the home. And I had a patient not too long ago that remembered the home health aide from 4 years ago. And it was like a little reunion, so they were just so happy to have that home health aide back, because we have such a great home health aide team. And it was great for them, great for the family. They felt very comfortable with that.
Right. It gives them that extra security of knowing.
That familiarity.
Right.
That the VNA knows me, my family.
Right. Now, if someone lives alone can they have hospice care if they don't have a support person around?
I just a recent experience with that. We had a patient who lived alone, and initially she did not require as much support. You know, we have the nursing services going in, and we have a wonderful social work team that initially goes in and does her evaluation. We knew that this patient was going to need more support eventually, and we were able to provide those services between the nurse that went in, the social work that worked with the family in order to provide extra services she would need.
Oh, to connect them to any other outside services.
Some private help,
Yep.
And our home health aid team that did a fantastic job. So we were able to keep her home, and that was her wishes, like her last wishes.
Yeah.
I want to stay at home. And we were able to do that. And we put the pieces together and made it happen. And it worked out really well.
Yeah. Do you find that of most people? They want to stay at home as opposed to going to a facility or to a house, you know, people that are at the end of life?
Most people do. But there's a certain segment, you know, that don't feel comfortable, you know, being at home, or I think more maybe with the caregivers.
Having that be what they're left behind with.
That's right.
Yeah.
That's right. And those memories.
Yeah.
And we're able to support them by helping get them into a skilled
Either
nursing
way.
facility.
Very good.
If that's not going to work for them.
And, you know, I can say both of my parents were on the VNA hospice services, and in the last 8 months, both of my parents just passed.
Oh, I'm sorry. Wow.
And without the VNA, we had my father at home. Great support, great team. You know, my family did an amazing job taking turns and helping, and I see a lot of families that do that. The siblings step up to the plate and they help take care of the parent. And my mother had to be in a facility with her end-stage Alzheimer's. My father was unable to care for her at the same time.
Right.
So we had both scenarios in a pretty short time frame.
Right.
And without the VNA, our team, who is amazingly supportive, you know, we were able to make that happen where my mom transitioned from home to a facility. So that's an example of the VNA services going with her.
Right. Both ways.
Yep.
So wherever we call home.
Wherever we call
is
home.
where it happens. Now, does someone have to remove a DNR from their wishes to be on hospice care?
A patient does not need to have a DNR or do not resuscitate to be on hospice. That's something that, you know, we support the patient's wish. We will do education with the patient about what might be some of the positive aspects of making the decision to have a DNR as their disease progresses, but it's the patient's wish that we support.
Okay. Now, I'm guessing, and I think most things that I've read, and you've probably read the same, that people think of hospice is for cancer patients, but there's many other diagnoses that would lead people down the same path.
Correct. Not only oncology patients, but patients with end-stage cardiac disease. My father had Parkinson's, Alzheimer's, liver diseases, end-stage renal, you know, just any diagnosis. And then we do have some patients that don't have a clear-cut diagnosis at the end, but they may be very frail and their functional status really declines. And, you know, we're treating the symptoms and not the disease necessarily at the end. You know, we really focus on the symptom management regardless of the disease.
So it's every case must be individual.
Very much so.
Yeah, yeah. So the cancer is a little bit of a misperception for most people to think of, tie those two together. It's always hospice and cancer, it seems like, yeah. If they're in the hospital, can they get hospice care?
Yes, they can. Under certain specific situations, primarily we use the hospital for patients who have extremely severe uncontrolled symptoms that we can't get under control in any other setting. So that can be at the hospital.
Okay. So they're covered either way. Who pays for hospice? That's one of those less than soft questions, but it is covered. by
Yes,
insurances
yeah.
and Medicare?
True,
Yes.
for both.
Yeah.
And like again, every patient is specific, and I know with Medicare, that's a portion of Medicare that people are able to tap into that portion of the benefit of Medicare, and that provides the hospice services.
Okay.
Many private insurances have a very similar option as well under their insurance coverage.
And I believe in Massachusetts that all insurers are required to provide a hospice benefit.
Oh, good. That's good to know, yeah. Now, believe it or not, we only have about 2 minutes left. So I wonder, is there anything that we haven't talked about that you want viewers to know about VNA hospice, hospice in general, of not to be afraid of it, or what the benefits can be?
Well, I think the thing to know is that hospice is a benefit package, and a lot more care can be provided for patient and family once a patient undergoes hospice. So if there's any question in your mind, to ask, to reach out, you know, to the hospice team. Speak to your doctor about whether or not this might be a good time to talk to the hospice team, and we're more than happy to go out and just do an informational visit and, you know, explain about what the benefit is, and help screen the patient at that time and see if it is appropriate for them.
So you can sit with the patient and the family and just have a discussion about
Right.
what hospice can offer and how is it different without anybody committing to anything.
Exactly.
So they need not be afraid. Good?
That's great.
All right, covered it all? People know everything now.
And if they don't, they're more than happy to call us. Again, you know, call our office,
Okay.
speak to their physician, and we can help.
We'll get them the answers. Very good. Well, thank you both
Thank
for being
you.
here today. I
Thank you
appreciate
for having
it.
us.
All right. And I'm Jeanne Sarnosky, wishing you good health and good health care.